Welcome back to the Dr. Nol program. And we have Dr. Finlay Macniel with us talking about prostate cancer and other related illnesses. Dr. Macneil, thanks so far for the very knowledgeable information we got from you. And I guess we were going to discuss a bit now about the biopsy and the tools you use with it. So if you can enlighten us a bit on that.
The biopsy, the common method of taking a biopsy today in Australia is called a transrectal ultrasound guided prostatic needle biopsy. And as I alluded to in the previous segment, just before the break, it does have its problems. And the one that really worries us is the risk of infection. Now, to get around that risk, there is another method of taking a biopsy using a grid which is applied to a different part of the body. And I'm going to show you this model, if I could please. This is a model of the lower urinary tract in the male, and it shows the bladder there, and if I pull out a pen I might even be able to show you a little bit better. The bladder just here, so this is a cutaway, as if an arrow is shot through the body, and the bladder is here, and there's a tube going all the way out to the end of the penis. That tube's called the urethra, and the prostate sits around the top end of that tube, and it's just in front of the rectum, which is just here, which is why we keep examining you through the rectum, because this is the only way that we can feel the prostate. Now, I was saying that the transrectal ultrasound guided biopsy involves putting a probe up into the rectum and then taking very careful scans of the prostate, putting some local anaesthetic around the nerves coming down and into the prostate, and then taking multiple pieces out of the prostate through the front wall of the rectum, which is where we get the risk of infection from. I also said that there's another way of doing it, and what we can do is we can actually take biopsies up through this way from behind the scrotum. So there's the testis and the scrotum there, and we can take biopsies up this way, and this is called a transperineal grid biopsy. There are a couple of advantages of the grid biopsy and some fairly major disadvantages. The advantage is that it's not going through the front wall of the rectum, so there's a lower risk of infection. The second one is that we can actually get to this part of the prostate just here, which we have, the very front part of the prostate, which we have trouble getting to from behind with the transrectal one. In reality, probably less than 10% of cancers are only are confined to this front part of the prostate, so that's not a big problem. Some of the drawbacks of this, though, is that in most places this needs a general anaesthetic to be able to take this biopsy, and there's more pain and bleeding after taking this biopsy this way. Both of these methods of biopsy are taking samples from the whole prostate, so they run the risk of missing the cancer. And that's where the MRI guided biopsy of the suspicious looking lesions, that's where it comes into its own, in that we are able to focus the biopsies on a specific area. Because up until the use of the MRI, we really were only able to see about 30% of the cancers using the ultrasound probe. So the ultrasound probe was really a very expensive site to put on a biopsy gun. Now I can show you a couple of these things. This is the ultrasound probe, and if you look at that, it's actually around about the same size as my finger. So if you have a digital rectal examination, this thing here will go in. And you'll see it's a lot narrower than the average stool. So unless you've got a real problem with your rectum or your anus, this is not an uncomfortable. It's uncomfortable, but it's not a painful procedure. The biopsy gun itself is this device here, and you may even have trouble seeing the needle. It's a very slender needle indeed, and it's passed along a guide over the top of this biopsy gun and goes into the, as I say, to the front wall of the rectum, as I've shown you before. And it is actually a spring-loaded gun, and makes, the worst part of it is the noise it makes, which sounds like this. And what actually happens is that it advances an in a bit and then an out a bit, all in a fraction of a second. and takes a biopsy in a little channel which is probably all but invisible to you, but is just here in the front end of the needle. So this device is a very good way of taking little pieces of the prostate. But the problem is we want to take pieces of the bit which has got the cancer so that we don't miss, we want to avoid missing the cancer. We also, if we do find a cancer, want to know how aggressive that cancer is. So I might just put a sheath back on this thing and do something you should never do, which is resheath the needle, and put that down there so it's a little bit safer. That's the current method that we use to diagnose the prostate cancer. But as I alluded to before, and I suspect you're going to ask, is who should we do this on?
Before I ask that question, because you're talking about the biopsy, and then there is another myth out there that they think when you cause trauma like cutting and put needles in there, you increase the likelihood of cancer, or you activate a benign to become malignant. I know it's a myth, but where do you think about it, and what would you like the public to know?
Right. Biopsies don't cause cancer. Choosing your parents badly probably does. We don't know a lot about what causes prostate cancer. It's probably 30% of them are due to smoking, but the rest of them, big myth, big mystery. The other common myth on that one is that by taking a biopsy you will make the cancer spread. And that's not true either. There is no evidence to support that particular myth. So be assured, if we do take a biopsy, be worried about the infection.
Yes, that's the most important.
But don't worry about the risk of spreading a cancer.
Okay. Well, you just made a point, and you just quickly tell us, now, how did they prove that smoking caused prostate cancer? What's the trigger there?
Well, what's the mechanism? We don't know. How did we prove it? No, we haven't. What we have are these studies of the whole population, and we see that smokers have a 30% excess compared to non-smokers of prostate cancer. So we estimate that 30% of the cancers we're seeing are due to smoking.
Okay. Most of our viewers, they smoke other than cigarettes, and they don't have the component that goes in their body similar. They just take the pure nicotine. I wonder if study being done to separate the two ways.
No. And again, that would be a population study. So studying a group within the population and say, now, who's smoking what? And that hasn't been done that I'm aware of. It might have been done, but it's not published in our literature. A lot of illicit drugs, really, the published evidence about them is fairly scarce. That is, it's hard to get somebody to say, yes, I smoke, whatever it happens to be, and to then study that group. So I'm afraid to say it's going to be a difficult one to do as well.
Yes, it is. Well, there was just another study released 6-7 months ago. It was a German study, and where they were saying coffee drinkers, and the heavy ones, like around 5 cups a day, have less chances of cancer, of prostate cancer. So how much do you know about that one?
Well, the straight answer is that it's a single study, and I'm always wary of single studies and of racing off to embrace the findings of a single study if were other studies confirming it. But the other thing, of course, is that it doesn't take into account any adverse effects from drinking 5 cups of coffee a day, which even for me would be a lot of coffee. And you'd probably have to scrape me off the ceiling. Look, there have been a number of studies which have looked at the effects of selenium, vitamin E, zinc in the diet on the risk of getting prostate cancer. And there have been very contradictory results from those studies, and in all probability there is no single dietary thing that we can say you need to swallow this and you will reduce your risk of prostate cancer.
Yeah.
There's no definite evidence of any particular dietary deficiency or supplement that will change your risk.
Okay. Good, Macneil. Let me bring you back to our main topic we were discussing about. And let's go. The question is, who is a candidate for a biopsy?
The answer is, there's two groups of men there. There's men who might have an early prostate cancer where you'd be contemplating treatment which would get rid of that cancer. There's also a group of men who have advancing disease in whom you wouldn't be thinking about curing this cancer, but you're going to treat it and relieve the symptoms. Now, by and large, the group with early prostate cancer have no symptoms. So early prostate cancer doesn't have symptoms. So that's why we need these screening methods, because you can't rely on symptoms. Advancing prostate cancer, most of us think about treating this if they're getting symptoms. So men with symptoms need treatment, and we've now got a whole range of treatments that are possible for those men with advancing disease. In general, there we're talking about disease which is either locally advanced or has spread to other parts of the body. Now, with prostate cancer, when the disease is spread to other parts of the body, you think, well, that's it, it's all over. But in fact, half of those men with treatment, half of those men are still alive and enjoying life in 3 years. So even prostate cancer that is spread is still a remarkably treatable disease.
Okay, Dr. Macneil, unfortunately we have run off time, and if you are kind enough, we would like to invite you to come back so we continue the subject and go a bit furthermore in other urological subjects.
Thank you. I'd be delighted.
Thanks for our viewers, and we will make sure Dr. Macneil is back so we can talk furthermore about prostate cancer and treatment, and as well maybe some of your questions about kidney, bladder, and other issues. Thank you, and see you next time.